Okay, while we wait, I just wanted to greet Linda. Linda, thank you so much for joining us this morning with your presentation. You're always such a value to our organization. We really appreciate you so much.
Thank you.
So good morning and welcome to today's forum hosted by the Georgia chapter of HFMA. I am Lil Kluk with FAM 360 and I am a Georgia HFMA Forum co-chair. Before we get started, a few housekeeping items. All phone lines will be on mute to avoid interruptions during the broadcast. Please submit your questions via the question box at any time. The speaker will provide their answers at the end of the presentation. You will also find a link to download the presentation in the chat box. The link will take you to the Georgia HFMA website under the tab titled In Case You Missed It. We'll also post a recording of today's session in that location. Everyone on today's call is eligible to receive continuing education credits for participating. Be on the lookout for the form in your email. You'll be able to use the form to self-submit for your credit on the HFMA website under the membership info tab. Now it is my pleasure to introduce the speaker, Linda Corley, one of my favorite people. Linda and I go back a long time. We've been doing these forums together for a very long time, and she's always so gracious to accept our invitation for presenting. Linda Corley, MBA, CPC, has worked with hospitals, physician practices for the past 25 years. Linda, I think it's a little more than 25. What do you think?
Oh, please don't tell on me.
She has served as a controller of the university-owned 4-hospital group and provided insight to clinical and financial members on compliant reimbursements. Linda is credited coder and frequent HFMA presenter. Frequent is an understatement, right, Linda? Can you count how many times you've done these presentations through the years? Give us an idea. How many times do you think?
Oh gosh, I don't know. 500 times?
At least.
And you know what? You are being so gracious, Lil. I feel like I probably know most of the people who are tuned in. So why don't you just skip all that stuff?
Well, let me just say that Linda is currently the Vice President of Compliance for Extend Healthcare. That's kind of an important piece. So,
Sure. Thank you so much. And I am delighted to be here to share this information with you this morning. Although I do visit around and I'm involved with some other HFMA chapters, Georgia is by far the best. And I think Georgia truly stays tuned in to educational topics that all of us need to learn about. So I want to express my appreciation to the Georgia HFMA chapter for being so thorough and just understanding that those of us in healthcare, particularly during these pandemic times, need all the information that we can get. So this morning, I'm pleased to talk to you about physicians and hospitals working together. I'm calling this integrated services. And if you think about even the past 5 years, certainly the past 10 years, hospitals or health systems have begun to employ more and more physicians and other licensed providers. And I think our challenge has been to be one cohesive group in the patient care that is being provided. Now, as you know, I am very much a reimbursement person. I am interested in being paid what I call the optimum payment, not maximum, because we're not going to go anywhere or do anything that we shouldn't do, but we need to understand what each payer is requiring for those services not only to be covered, but to be reimbursed at the optimum amount. So I'm still, even though I'm a reimbursement person, I'm still very much concerned about patient care. And I think particularly, I even hate to say this, but as I get older, I'm more and more concerned about how Medicare and Medicaid are changing coverage and reimbursement patterns. And I think it becomes even more important for us to understand within the healthcare industry or area, all of us who are providers, to make sure that we know the rules. Certainly, that's part of my compliance title. But I think the rules are what reimburse correctly or appropriately. So, what do we know about the past 10 years? Certainly, pay for performance and value based purchasing. Still, I think one of the most important decisions, particularly that a hospital makes today, is, am I providing the services that this particular patient needs in the correct setting according to the medical condition of the patient and the insurance coverage provisions that this particular patient must meet? So I say there, payer specificity requires our understanding. When I first started working with Medicare, I think that we took the approach that as long as we met those Medicare guidelines, then other payers were pretty much going to step into those same reimbursement patterns. But I think today, because we have Medicare Advantage plans, we have not only Medicaid, but we have Medicaid HMO or CMO plans, all very different in what's required in order to be reimbursed. So this particular presentation is all about understanding, first of all, how will our physicians and hospital clinicians or staff members work together to meet these reimbursement requirements. Then I think we're all stuck on quality. I think the Affordable Care Act, when it was passed, talked a lot about quality, but quality comes down to, is the patient receiving the care or services that he or she needs according to their medical condition, and have we presented that support for patient care that's necessary? Certainly since 2015, we've had these ongoing changes. Patient outcomes, how we report those patient outcomes, certainly drive reimbursement. We need planned outcomes that are attainable, and then we need to consistently obtain results from our patient care plans and from protocols. And I think for the first time ever, I am seeing more and more collaboration with the clinical side or patient care, along with those of us who are on the financial or in the revenue cycle side. Certainly, that coming together, our having written policies and procedures, plans for patient care, all of us understanding the same payer specificity is extremely important. And again, we're going to talk about preparation and some actions that you may want to consider for effective reimbursement. To me, it's all about cash flow, particularly as I am working with our client hospitals during this pandemic period. Certainly, patient volumes have changed. The care that a particular patient may have changed. We are seeing more telemedicine, and I hope you're focusing on that to see how that can increase your patient care volumes. But simply being in a different healthcare environment, I believe, is placing more emphasis on our understanding reimbursement. According to CMS, what were we supposed to do back in 2015? Efficiency in our delivery of needed care. And I don't know about you, but like Lil referred to, I have been in and out of hospitals for well over 30 years. And efficiency is simply not a word that I would use to describe our operations. That does not mean I think our operations are bad. I simply think that we don't often plan for either the expected or the unexpected. So making sure that not only when a patient presents to the ER, if he or she has a particular chronic illness, we need to understand both from the clinical and the financial perspective the services that that patient should receive for patient care, but then what we need to have in place to ensure those particular services will be covered and reimbursed. And when I see that second sentence there, I've been saying this for years. Strong financial incentives for providers to slow cost growth through, through improvements in productivity and efficiency. But don't you think that CMS is doing all it possibly can to decrease our financial incentives if we are not providing those positive patient outcomes? Just yesterday, I was reading about the new radiation oncology bundled payment system that is going to come into effect for some hospitals on January 1. So we continue to see more and more what I would call either packaged reimbursement, certainly bundled, and looking at value-based services so that what we are being paid is being reduced. Our challenge, I think, is to slow our cost growth, if at all possible, and manage these reimbursement methodologies or programs that Medicare and Medicaid are pushing us toward. And I do think high quality care is what we all want. I've never walked into a hospital that was not concerned about the patient receiving the exact care that he or she needed. I think continuum of care, as we've talked about before, has become extremely important. We are certainly not in that episodic care that we started with, way back when Medicare first began. Whatever CMS reimbursement model I look at, particularly preparing for 2021, they are all needing or dependent upon hospital and physician collaboration. If we think about provider-based clinics, even our freestanding clinics that are paid under the Medicare physician fee schedule, some of these we'll talk about in brief. As you know, each year when we find out about ambulatory payment classifications, which are our outpatient hospital payment system, we see more and more comprehensive APCs or packaged services. I mentioned to you radiation oncology, certainly MSDRGs have been refined, and I think particularly CMS has been able to work very closely on MSDRGs because of ICD-10. As you know, we continue to talk about how specific ICD-10 diagnoses can be, but of course we need that all-important documentation to be able to code the principal diagnosis and the other services that have been provided based on that patient acuity and the intensity of the services that we are providing. Present on admission, we'll look at just briefly. Quality reporting certainly continues to be one of the most important aspects of reimbursement, and then bundling I've already mentioned. All of these reimbursement models require the services the hospital is providing at the request or at the order of the physician to be in conjunction with each other. This slide I think is very old, but it always gets my attention. Way back in 2014, CMS said to hospitals, 60% of cardiac caths may be unnecessary. Well, if you look at the reimbursement for diagnostic cardiac caths, it has grown smaller and smaller each year. I think the reason for that is Medicare continues to look at, was that particular cardiac cath necessary, or was it ordered simply because we felt the patient needed some type of diagnostic test? Now, certainly, I do not stand before you here as a physician. I am not. But when I review medical records and I see exactly what that second bullet says there, 37% of cardiac cath patients had no blockages. The caths were performed based on irregular heartbeats or abnormal findings from lower level diagnostic testing, but the patient may have not had even a history of heart disease. So as we see our reimbursement for cardiac casts continue to decrease, to me, this brings up how CMS or Medicare will identify a particular area for very close attention. What type of patients are being treated with this diagnostic service? What are their presenting diagnoses or their presenting problems? And then that bottom bullet, you see there 40% of repeat laboratory tests for the same patient on the same date of service already had current test results in the patient's medical record. What has traditional Medicare carried out for outpatient laboratory testing when it's performed on the same day as other services? We are no longer paid separately for outpatient laboratory testing if there are other services on that outpatient claim that are going to be reimbursed. So this focus I continue to keep in mind only because I think it teaches us when CMS gives us an alert or a bulletin or brings to our attention a particular area of reimbursement, much the way they are doing with radiation therapy, chemotherapy right now, certainly looking at greater bundling services. Those are in the works. Medicare started out talking about 2023 for more bundled services. Now they are moving that to 2021. We don't have the full guidance on those bundled services yet, but I bring it to your attention just because I think this is where, for reimbursement, all of us should be placing our focus. Changing care paradigms, I know you see this in the work that you're carrying out. In the past, we may have looked at immediate clinical needs. However, now we are focusing our programs and our plans on the comprehensive needs of the whole individual. Patients in the past were the recipients of care, the focus of the care team. Now, even Medicare is reimbursing for what we call patient and family reviews or discussion of their medical condition so that the family is educated on the care the patient may need. Certainly, they are active members of our care team when we are looking at working on the continuum of care for that particular patient, as you see there on the bottom of the slide. Understanding the immediate need that my patient presents today, but then making sure that a clinical individual or person is involved in the continuum of care, I think right now presents a great challenge for us. So I'm going to ask some questions and you think about how you see these particular areas of your healthcare environment. What 4 healthcare reform initiatives that began, as we talked about way back in 2014, related to clinical patient care may be lowering your payments for 2020? And then I think the biggest question for us is, can our physicians and our hospital team members produce a positive effect on all 4? Not only do we have to know, can they produce a positive effect, we have to plan to have in place the outcomes of that patient care to be positive. What long-term reimbursement methodologies should your facility, particularly acute care hospital, address every month? And then the biggest area I think that we have needed to show improvement and simply changed methodologies is in patient care management. If we look at the areas of case management, utilization review, discharge planning, and then I know that most of you are involved in a very active clinical documentation improvement program. To me, all of these areas of patient care management represent where we will either increase our reimbursement or whether we will lose that reimbursement to poor practices. So I'm asking you to rate your patient care management on a poor, 1 or 5 excellent scale. And I'm not asking you to do this as a reflection of the people involved. I go back to my old training about the 3 things that we truly have in a healthcare environment to show improvement. We either have to show improvement in our people, which generally to me means training, our processes, and I find many more, I don't even know whether to call it problems, but I find many more gaps in our processes than I do either with our people. Our last component would be technology. And certainly our technology is continuing to change. But I also see that even though we may have improved technology, I don't know that we have improved the processes that that technology requires. So if I look at my people, processes, and technology, think about your strengths, and every healthcare entity that I work with certainly has strengths. But then I think if we look at our weaknesses, or some people like to call those opportunities, that's where cash can be increased by strengthening our processes, having written policies and procedures that I mentioned to you, and understanding. I think one of the biggest challenges we face, we will move our employees around to different patient care areas, and perhaps those processes or workflows or procedures are not well spelled out. And then I want to place our physicians in the center of that patient care management. Not only must I have a strong um, case management utilization review team, I also must have a very strong link to the physicians that we know or are ordering the services, providing the services, and understanding the patient care that is needed. So I want to ask, what role do your particular physicians play in making these decisions for patient care management? And then, of course, since I am a reimbursement person, I have to ask, what total dollar amount did your facility write off last month and even year to date due to the patient being placed in the wrong setting, either inpatient, outpatient, or observation? What services did we write off because they were deemed by the insurance company to be not medically necessary? And then, of course, I've been working with several hospitals just in the last 3 months on unauthorized services. Now, I will be the first to admit to you, I don't have a magic wand, but all of these particular decisions being made by our physicians and our patient care management group depend on collaboration of the two. And some of the hurdles are very difficult, particularly when I start in working with services that now require authorizations. The payers oftentimes are not quick to answer our inquiries. They often have hurdles that we have to jump over, so to speak. But understanding what's required, I do think is half the battle. I also will mention to you or simply remind you that Medicare, traditional Medicare, began authorizations for, I think, 4 different areas on July 1, and Medicare, traditional Medicare, is adding some authorization requirements on January 1 for some of our radiology imaging procedures. So keep in mind, we no longer can say that Medicare does not require pre-authorization or authorization, prior approvals, whatever we want to call that process. A very different methodology required in your scheduling and patient access. So here we are with Medicare reimbursement. No surprise to you, I am sure, that for this year, 2020, a hospital may lose 6% of its planned Medicare reimbursement. Again, this is traditional Medicare fee for service, based on these 3 areas of quality reporting: value-based purchasing, hospital readmission reduction programs, and then hospital acquired conditions, which we refer to as present on admission. When the patient came to us or presented for service, he or she had a particular condition that is being treated, or did it develop after after the patient began receiving services. And as you can see there, some of these go all the way back to 2013, but just about every hospital that I'm working with still, we still have challenges with readmissions and also with hospital acquired conditions. So I'll always like to bring those to your attention. As I've said to you, what one department can increase physician and patient satisfaction, and I believe generally increase payment for all payers. The care certainly is driven, as we've talked about, ordered and delivered by physicians or other licensed providers. Physician interaction is so important with our hospital care managers. And there you see at the bottom why I am interested in this. Case management often is involved in patient status. And again, I would say to you, a review of the uh, care plan and the presenting diagnosis for any inpatient, not just Medicare, but any inpatient should be reviewed just as quickly as possible. I prefer review before the patient is even placed in a bed, but if that's not possible, at least have a clinical case manager review that physician order and documentation for the care plan for any inpatient before that patient spends a night in inpatient status. Again, difficult to manage, but even if you have a case manager on call who is reviewing some of this information, I think that will be beneficial. Utilization review, certainly for our authorizations, discharged planning. How many times do I see a patient who, according to their DRG, should have spent 3 days in our inpatient care? And sometimes I see that that patient may have spent as many as 7 days. Now, not all the time, but we still have difficulty with discharge planning. I believe it's an area that can be improved simply through understanding what the principal diagnosis will be after the patient has been cared for, making sure our documentation for intensity of service is there, and then knowing what that principal diagnosis will correlate to as far as a DRG, and understanding what Medicare calls that geometric mean length of stay. In other words, what I think Medicare is saying is that we are going to pay you for 3 days of care according to this diagnosis and DRG. If you keep the patient longer than those 3 days without either a complication or a comorbidity that needs to be treated, and very clear documentation that can be coded, then you will have just lost money on that patient. So, discharge planning, understanding approved days, and having that plan in place or process in place to ensure the patient is receiving the care that he or she needs and then is being appropriately discharged is all important. And of course, I'm kind of stuck on clinical documentation review. Patient acuity and intensity of service is what's going to be evaluated based on the documentation for that patient. I do think this has been a cultural change. And I know that we in hospitals, particularly, and physician practices, all we know is change. I don't think anything in healthcare has remained the same for at least the past 15 years, if probably not longer than that. So, the hospitals with whom I have been working, hospitals and physicians, I think all of them have come to the conclusion that yes, it's true, we need to work together because of this reimbursement uh, environment that we're in. And I think we've agreed on that. But the part that is difficult is we can no longer just give that lip service because we know simply talking about, yes, physicians, hospital or clinicians, clinical team members, all of us need to work together. That's not going to get us where we need to be, not only with patient care, physician satisfaction, but certainly with reimbursement. And I think a lot of the hospitals with whom I work, they simply decide on this is 2020. Let's put what has happened in the past, leave it in the past, so to speak, and go forward to align patient, physician, and hospital interests. And I think we want to equalize each of those parties' importance. Certainly, we're interested in what the patient needs, no doubt about it. We must have that physician's understanding of what's important and him or her physician being able to express that. But then also, we want to bring forward, I think, just a little bit the hospital or the health system's importance in not only delivering these services, but understanding what the processes will be in order to deliver. I think we need that new vision. We often talk about it. What does success look like for each one of these three parties? And then I want to identify specific improvement through working together, collaboration opportunities, and having co-management of clinical and operational standards and procedures. Absolutely, I need that physician's care plan. But at the same time, perhaps the physician and a care manager, and sometimes even a coder these days, can work together to come up with not only the documentation, but the approach that is going to be taken for this particular patient. Quality of care, technology, financial, clinic, and hospital operational governance is extremely important to us. My facility may be involved in research, and then I want to bring payer contracting to an understanding of what's required, as I mentioned, for that payer specificity so that we can be reimbursed appropriately. I think we have to start small, and I know every one of us thinks that we just go from one initiative to the next as far as reimbursement is concerned. But I think particularly with our number of employed physicians, with the number of clinics, I see urgent cares opening. I see all types of outpatient services now being provided in different areas so that we no longer simply talk about hospital outpatient services. We talk about our outreach and growth into the community so that the hospital or health system is seen as a vital component of what all patients may need in order to maintain their health status. So I'm saying start small with a couple of projects that you want to improve. I'm going to give you a couple of examples. If you've got any past grievances, talk about those and get them out of the way. Agree on what your goals will be. You have to have some metrics. You have to measure whether you are improving or whether you are staying the same. I think evaluation is extremely important. All along the way, you will need to realign. I have not worked with a single hospital that we said, okay, here's our plan. Here are our goals. Here's what we're going to do, how we're going to do it. But as you begin carrying those out, I think it's important to keep in mind that this is change. So in order to implement change, we often have to consider other important parts of the puzzle in order to get to success. And then I think when you start with some small goals, you can move on to larger undertakings and have success. Hospital readmissions, I'm not going to spend a lot of time on, but please know where you are with your hospital readmission accomplishments. You see there, I think there are 6 conditions right now that are reported and tracked as far as Medicare hospital readmissions. You can see there for 2020 and for 2021, you may lose up to 3% of your particular Medicare hospital specific reimbursement, not budget neutral. In other words, if someone else is gaining reimbursement, a hospital must lose reimbursement because it's going to be up and down across the United States, depending on the quartile that you fall into. Back in 2019, about 2,610 of 3,300 hospitals incurred a payment reduction of about 566 million. Again, I keep these statistics a little bit old, but they still get my attention simply because I understand improvement means additional reimbursement for the facility. Um, and then I'll mention to you, because I get asked this question quite a bit, cohort diagnoses. Now look at those listed there. If the patient has aspiration pneumonia, a principal diagnosis of sepsis or respiratory failure, and a secondary diagnosis of pneumonia present on admission, those cohort diagnoses are going to qualify that patient to be considered part of this readmission calculation. Impact of expanding the definition that we have over the past 3 years means that there has been a major increase to the number of cases and the number of hospitals meeting or qualifying for this particular measure. Again, I would encourage you to know what your particular performance was for 2019 in this area of readmission. And again, I won't spend a lot of time with this information, but look at a couple of these. 69% were non-compliant with medications, and that's truly not surprising for a Medicare beneficiary. Some of them are elderly, need help, and we'll talk about a couple of ways that you may want to provide that. Let's see, 37% had no follow-up visit with a physician or admitting specialist. That always gets my attention. And I would ask that you pay particular attention to when a patient comes in as an inpatient and he or she certainly is managed by the admitting physician. But if that patient's care is turned over to a hospitalist, make sure that outgoing the hospitalist and the admitting physician have decided on who should provide follow-up care. I am seeing that more and more, leading to confusion during the time the patient is being discharged. A new approach. Now, here's a success story with a hospital with whom I have worked, still ongoing, but they were concerned about their readmissions. So the hospital collaborated with their primary care or specialty clinics to set patient appointments within 3 days of that inpatient discharge, particularly for their chronic conditions. Now, and I know that most of you are already doing this. So certainly I don't know when I could tell you that I have seen a patient medical record with a patient who was an inpatient who was not discharged with a follow-up visit. However, in this case, the clinic visit report was shared with hospital UR team to validate patient care for ongoing stability. So in other words, when that patient when that patient discharge was carried out, there was an appointment set with either a primary care or specialty clinic within the healthcare system. And the clinic visit report after that discharged patient had come to the clinic and been evaluated, that report was shared with the hospital UR team to validate patient care for ongoing stability. And yes, this does cost money, to have a clinic reporting back, of course, electronically to the care management team so that the patient can be followed for that continuum of care. Then a UR member or a member of that care team telephone the patient weekly to record patient progress or condition, particularly for these chronic conditions, diabetes, congestive heart failure, COPD, cardiac-related diagnoses. I think it's extremely important that our patients who are more acute or sicker, as I would call them, are the ones that you want to focus on, because those are the patients who are likely to have an exacerbation and need to be readmitted. I also want to mention here that 2020 gave us some new codes for remote physiologic monitoring. So now I see this particular hospital client working with their patients not only by telephone, but also through their patient portal check in, through those new remote monitoring services that now can be charged and billed, and simply maintaining what is called a technology communication based service that does not have to be by phone, it can be by email. Depending on the patient's consent, I need to get that in. But understanding what's available in this particular area of patient follow up, and then do you have your plans in place in order to follow along the continuum of care, particularly chronic condition patients, I think will result in a lowering of readmissions. Again, after you are or a member of the care team communicated with the patient, they would then follow up with the clinic if they thought that patient should come in for a visit, or perhaps these days have a telemedicine visit. The system reduced their readmissions by 37% in the program's initial 6 months. And I checked with them back in the summer of this year, and they were still about, even though they've improved their readmissions, they were still seeing between 22 and 25% improvement in their readmissions on a quarterly basis. And I think that is the importance of continuum of care. No longer can we allow that patient to be discharged and simply wait for the time that the patient may need an additional episode of care. This focusing on the patient, and think about what this does for patients as well. Builds patient satisfaction, of course, certainly assists with the physician, both in hospital physicians and in the clinics, whatever primary or specialty care that a particular patient may need. And there are new codes for following the patient with chronic conditions that the physician can charge and bill, and even providing transitional care. So all of this is important, I think, for us to understand what's available and how can it be used. I think the new patient experience is certainly real, so to speak, understanding what patients are looking for, how they want those services to be provided. And I think simply having the patient understand the desire of both physician and hospital is to meet their patient needs. I always say, now think about, I pretty much grew up in the business office. So, we're always talking about patient access, but I did try to supervise patient access for 2 years for a hospital at one point. It was the most difficult job I ever had. But I do like to say the final bill does not originate in the billing office. Where does it begin? Way back at the beginning of the revenue cycle. And I know that's not news to you, but please look at your processes. Understand what your opportunity versus reality may be. And this is the first place or the first component of the physician and the hospital working together to provide the care the patient needs. I think you need to know your strengths and your weaknesses again in the areas of patient registration and all those things that go in with registration, eligibility, financial counseling, whatever copay is going to be required. All of that information is necessary every patient. And in surgery scheduling, I've begun to focus on simply because once surgery is scheduled, that presents an opportunity to ensure coverage criteria are met. We have the appropriate documentation for medical necessity. We are looking at financial, whatever is needed. I mentioned eligibility, financial counseling, all those things. And I am seeing more financial counseling for outpatient services simply because they have gotten more expensive. At the close of the presentation, I do have some more slides on patient access. Certainly do not have time to go through them now, but if you have questions or if you want to discuss any of the information in those appendix slides, please just let me know. I'm always talking about Medicare's Advanced Beneficiary Notice, what we call the ABN for outpatients. And then I'm also focusing on this year the inpatient hospital issued notice of non-coverage, which Medicare calls the HINN. I get a lot of questions about centralized versus decentralized. I think it simply depends on your particular facility and what may work well for you. There are good components of centralized as well as there are outstanding components of decentralized. I do think you have to ensure by name, not by job role, but by name, who is going to be accountable for ABNs and HINNs. Must have my process, my workflow in place, but then I've got to go one step further and make sure the individual who is responsible for that ABN in an outpatient area understands what that responsibility entails. As you know, I'm big on written procedures for both medical, financial, clinical staff responsibilities, certainly clinic responsibility for medical necessity of the ICD-10 diagnosis if that clinic is sending a patient over to the hospital. And then hospitalists, I am finding, can assist with those HINNs. And I'm seeing many of them take an interest in what is required, coverage criteria, understanding when should this patient be discharged and how are we meeting those requirements. I do think ABNs and HINNs are a necessary quality of care determination, starting with physician education, registrar with care management resource for the ABN, and I do think the HINN does need to be a clinical team member, either the hospitalist or a patient care manager. But that patient care manager needs an established relationship with the hospital's physicians to promote quality of patient care and appropriate patient discharge. And I do think patient responsibility has grown in importance to us. I'm sure I don't need to tell you that, but understanding the patient's perspective based on what he or she will owe as the patient responsibility amount is extremely important. Observation after outpatient surgery, I probably said this to most of you before, that is non-covered by Medicare. In other words, I should not allow my physician who is scheduling an outpatient surgery, same day surgery, to request observation just as a matter of routine. I call that bed and breakfast because Medicare is not going to reimburse, and most other payers as well are not going to reimburse for that patient staying overnight in observation after outpatient surgery. So I say no scheduled observation. Certainly, if that patient has a true medical complication that is documented, that patient can be placed in observation. But what I'm speaking to you of is simply routine observation after an outpatient or same day procedure. I also mentioned there nausea and vomiting generally are not complications because what Medicare says to us, that patient can receive a medication either over the counter or even a script for a medication to take care of nausea and vomiting. They should not be retained in the hospital overnight. And of course, we still, I think, need to understand the battle about unsubstantiated chest pain. Hospitals have given back or allowed Medicare to recoup inpatient payments, more inpatient payments, billions of dollars based on chest pain or suspected cardiac diagnosis than any other problem that we deal with in the ER. Chest pain unsubstantiated by lab, which would be cardiac enzyme findings, not substantiated by an EKG, not having a history of cardiac related problems, is going to be denied as not meeting inpatient criteria. So we should be educating our physicians, particularly in the ER, and our hospitalists about the ability to use observation for appropriate patient care. This slide I probably have already said to you. Certainly the difference between traditional and Medicare Advantage plans is important for reimbursement. Commercial, I'm surprised that we have such a variety of billing requirements. I would mention to you the National Correct Coding Initiative edits. I cannot find a payer that does not use those NCCI edits to deny component services if there is a comprehensive service or CPT code on the claim. I would just ask that you look into what's happening with our claims based on these NCCI edits. Sometimes the payer will deny the comprehensive service and pay the component, which is going to be a lower reimbursement. So all of that extremely important for us to understand. Compliance edits as far as medical necessity. I don't know a hospital that I work with, and I apologize that I'm ranting and raving this morning. I don't know a hospital that I work with that does not check for medical necessity, but the process in place after we determine whether we have a diagnosis that meets medical necessity is all important. And then this is another success story, particularly about oncology or chemotherapy. The situation that I was asked to lend some assistance with was following outpatient chemotherapy treatments. Patients were being admitted, staying overnight due to adverse symptoms, primarily again for nausea-related care and a treatment plan to ensure that that patient was appropriately well enough for discharge. Now, I'm sure there's a better medical way that I could say that, but they were keeping the patient overnight, most often as an inpatient, simply because the physician did not think the patient could be safely discharged. The services did not meet inpatient criteria, and they were leading to significant write-offs. So what did the hospital and the physicians do? They agreed to dedicate 4 observation beds at the oncology center or cancer center. Nurses received additional training on monitoring symptoms. You know, what is a true complication after a chemotherapy administration of a drug? Or what are those symptoms that we know may take place that certainly need to be treated but are not severe or serious? The physicians sat down and agreed on approved outpatient protocols for up to 18 hours of care. And this was an important hurdle to get all the oncologists together and say, what do you want for your patients after their chemotherapy treatments? What should we look for as nurses? What services should we be providing? And how long do you think that that particular time frame should be? Patients who cannot be discharged after 17 and a half observation hours are now reevaluated for inpatient admission. Then a new physician order is written if that patient's condition now meets inpatient criteria. And I have a little reminder up there on the slide. Keep in mind that Medicare's 2 midnight rule may support or often supports inpatient admission simply by that physician documenting the patient cannot be safely discharged. Here is my plan from the physician, and here are the adverse conditions that are being followed. The center, the oncology center, and the hospital nurses huddle each morning to discuss patient schedules, medical problems from any incoming patient phone calls, and the prior day patient treatments. Utilization review actually follows up by contacting the patient between appointments simply for a medical condition check to access the general medical stability of the patient and his or her readiness for the next planned treatment. So this is a lot of activity, I think, planned activity to make sure, first of all, the patient is receiving the care that he or she requires. Certainly improved patient satisfaction. All of this is discussed. The patient understands what may happen. The patient is involved with providing their symptoms or their, how they are feeling, their conditions after the chemotherapy treatments. So it's a much more participative environment. There is certainly a more controlled flow of patients and care. This does meet the physician's desire for quality patient care. No one is discharged that does not meet the request of the physician for further care, or even the patient's um, talking about how something does not feel right. I've looked at these medical records, and it's so important and interesting to see the collaboration of the physicians based on the protocols, the care plans for after treatment, and then the nurse's involvement in how that patient is going to be treated going forward. And the good news, of course, for me, improved reimbursement for all payers, not just Medicare, but having this very structured approach to how patients will be treated, how they will be cared for, how the documentation will be captured, and ongoing for that continuum of care. It is true collaboration. They put together, the physicians and the hospital together, the oncology center, a management action plan that identified their strategy, the actions they were going to carry out, what outcomes they wanted to see, and in the beginning, simply assessed every day in a late afternoon meeting how the program or how the procedures were being carried out. Uh, I think it's important to incorporate facility or location specific best practice operational procedures. Talk about what is ideal, what do we want to see, how can we put that in place, what's important as we started out talking about patients, physicians, and the hospital or the facility itself. Certainly, ongoing evaluation, constant and consistent plan analysis and adjustment, and then simply re education, looking at lessons learned into those facility specific processes for continued improvement. I think these are the steps that can be designed to improve patient experience, physician satisfaction with how the patient is being cared for, and then, of course, I have to put reimbursement. Another small example, and I know I need to hurry here, collaboration of clinical and financial team. We do have a client that has a 4-person, what they call simply their clinical financial team, or CLIN-FI. This team of 4 members rotates quarterly through their hospital-based clinics and even some of their freestanding physician offices to hold 15-minute payer-specific sessions with the doctors. And some of these I see in as little as 5 minutes with the physicians, but I have specific details on what's good and what's not so good to share with the physicians so they are continually being updated on how patients are being cared for. Also, this team of 4 people may hold 30-minute sessions with the office care team and the front office staff and look at what they're covering. Varied, tailored, or I would say very specific messages depending upon relevance to the office, claim denials. Now, not any in great detail, but talk about the diagnoses that are not being paid, or talk about a particular chronic condition that needs to be addressed in a different way. Missed authorizations, updated coverage guidance. Think about as we get ready for 2021. We have the proposed CMS outpatient prospective payment system guidelines. We do not yet have the final rule, but there are some changes there that I would mention to you as you prepare for 2021. Certainly documentation improvement opportunities, and then if we do have any patient concerns that have been expressed, certainly any complaints, and then I'm seeing as a part of this overall collaboration of physician and hospital team members, thank yous coming from patients, and those are so rewarding. Just this simple collaboration, 15-minute or less meetings with physicians, 30-minute or less sessions with the office care team and then front office staff for this particular facility has increased their cash by about 22% over the year previously. And that, sometimes I look at that and I think, wow, that's a lot. Sometimes I look at it and think, gosh, I thought it would be more. But anytime that we can increase cash coming in the door for particular locations by 22%, I think that's important. So where are we now? How will your specific clinic, facilities, outpatient locations positively affect these payment methodologies? Education is key, but sometimes I think we know the rules, but we don't put the rules in place or we don't follow the regulations. So, my thing these days is simply translating all of that guidance, all of those requirements coming from our payers into practical how to's. It doesn't do me any good to put a process in place that is not workable. That means I've got to include the people who will be carrying out the task in my how to. I want to move patient care staff members, patient care management into the revenue cycle, or certainly within revenue integrity, and involve them in daily collaboration with all others to assist with action plans. And of course, those are our revenue cycle areas there that we can improve through more involvement with our patient care management. I think physicians should be included more often in discussions, particularly since we have Skype or Zoom or Teams or whatever we want to use. We don't have to have the physician on site now to have that 10-minute discussion with him or her. I want to be sure that they're included in important discussions, certainly any decisions involved in the areas in which their patients are being treated, and then understanding procedures, what is required. All of these particular components should be our focus. Here we are, what can be done, and I know that you've seen these before. I do like to have a management work group, have the information or our data readily available for us to discuss. We may need to analyze specific aspects of that and then come up with our management action plan, as we talked about, with ongoing monitoring. Here are the people that I would involve. Certainly, your particular organization may look at this and say, gosh, that's way too many. So I want to break it down into smaller groups. And here are the questions I would ask you to keep in mind, not only for 2020, but as we prepare for 2021. How are we measuring and reporting patient care outcomes and quality of care? Are they being addressed at both hospital and clinic levels? Active participation in all pay for performance practices, a hospital priority. Can't just be financial. We've got to include our clinicians. Am I, me as an individual, an active team player in initiating process improvement? Sometimes I see people simply sitting back, expecting others to take the lead. But I think at this point, wherever we are within the revenue cycle or on a clinical care team, regardless of our position, we've got to forge ahead and bring others with us. Do I know my hospital's 30-day readmission rate? Is it communicated? Do we have a goal? Is it clear? Are we tracking our performance? Which person or team is accountable for performance tracking, measuring, and reporting? And that management action plan we want to have in place. What are my hospital's current HCAHPS and MAP scores? Extremely important. And am I and my staff able to make improvements in our partnerships with physicians and other hospital leaders? And I think we are at a crossroads for change. Certainly the pandemic has brought this on even a little more quickly than I had been experienced in the past. But I do think we need to talk about change management. Certainly some of the almost overwhelming challenges that we are facing. I think success certainly comes in all of these areas, and I won't read those to you, but simply knowing that we are improving. And I don't think that improvement has to be quick. I think it can be very slow, it can be steady, but understanding that we are addressing our patient care needs, meeting our physicians' quality of care standards, and then simply understand what's happening with reimbursement is all important. I am sure I am over time, but I will ask if there are any questions. And I cannot see the chat box, so Lil, if you would help me with those, that would be great.
Absolutely. Right now, there are no questions that have been posted, but we'll give it a minute in case there's some folks that want to ask the questions now. So we'll just give
It was a lot of information.
a lot of information, valuable information. Linda's always, again, can't say it enough, how much we appreciate your time and all of your knowledge. It's just a wealth of information. Thank you so much.
Oh, thank you. And if anyone wants to send me a question, please do. It's always good for me. When you have questions, I'll be glad to answer by email and then copy Lil, and they can put them out on the HFMA website. So anything that I can do to help, I will be glad to.
That's awesome. Okay, so thank you again for joining us today. Stay safe. Have a great day. And be sure to join us for the next presentation at 11 o'clock, which is avoiding the 5 mistakes made in TPL collections. Thanks again. And again, if you have any questions that you think about after the session with Linda, you've got her email address. Feel free to reach out to her. Feel free to reach out to me, and we'll make sure to answer whatever questions you may have. In the meantime, stay safe, have a great day, and we'll talk to you at 11 o'clock. Thank you.
Thank you.